Good afternoon. Welcome to In the Trenches with DAC. Today we are going to talk about syncope. Syncope is a very common medical problem, and often we see multiple admissions per week with syncope, and you need to have an approach to it. Number one point, syncope is a cardiovascular disorder. It's not a neurologic disorder. It's a cardiovascular disorder. Other neurologic conditions could cause loss of consciousness, especially seizures, but they are not syncope. When you evaluate someone, the most important thing to do is do a history, an exam, and an EKG, and then you can generate your differential. So let's talk about how you approach the patient with syncope. Let's go through the causes. The most common cause is something called vasovagal or neurocardiogenic syncope. After that, we have cardiac syncope, and this constitutes a spectrum of disorders. Number one, you have arrhythmias. You can break these down into bradyarrhythmias and tachyarrhythmias. Then you have structural heart disease, which is aortic stenosis, hypertrophic cardiomyopathy, and pulmonary embolism could be placed in this category, and it's not a common cause of syncope. Then you have orthostatic hypotension. The orthostatic hypotension could be physiologic or pathologic. Few other things that should be mentioned: hypoglycemia and psychogenic. So let's go through how you approach this. The most important question you could ask the patient with syncope is, did you feel a prodrome? That is the most important question. Now, you want to divide these causes into life-threatening and not life-threatening. So the most common cause that we think of is vasovagal and neurocardiogenic syncope, where a reflex gets triggered, where you have a lot of sympathetic tone, and then all of a sudden you get a vagal surge, and that's a combination of vasodilatation of blood pressure and low heart rate, and that causes transient decreased blood flow to the brain, and the patient goes out. These people feel a prodrome, often diaphoresis, nausea and vomiting, vagal surge. Where could you see it? You can see this when people get queasy, when somebody's getting blood drawn. We have episodes when somebody is very upset. In the olden days, you used to see a horror movie. A lady would look in the mirror and see a monster, and she'd scream and she'd pass out. But these often they're precipitating events. Sometimes there aren't any precipitating events, but the patient feels a prodrome. Now, there's subcategories of this, that it's really the same mechanism. Cough syncope, okay, you have somebody extensively coughing and it elicits a vagal reaction and then they go out. Micturition syncope. So a man's urinating and gets up late at night and he's got a big prostate, and he urinates, and then he falls down and he blacks out, called micturition syncope. There's something called carotid sinus syncope. Okay, with this, you have a hypersensitive carotid sinus. Often someone's wearing a tight collar, they turn their head and they stimulate a vagal reflex. These all have a prodrome, and often the EKG is normal. Now, what about cardiac causes? So you have brady and tachyarrhythmias. Bradyarrhythmias, usually seen in the elderly, usually due to variants of sinus node conduction system disease, sick sinus syndrome, most often seen with second-degree heart block, Mobix 2, or third-degree heart block. Okay, this involves conduction problems below the AV node, infranodal, and this is also known as Stokes-Adams syncope. And you treat this with a pacemaker. Now, tachyarrhythmias could also cause syncope. The most common tachyarrhythmia are ventricular arrhythmias. So ventricular tachycardia could cause syncope, and this is probably the most serious cause of syncope you don't want to miss, because VTach, you could die from that. You could also see it with supraventricular tachycardia, but much more common with VTach. Now, usually, not always, usually these patients have underlying structural heart disease, possibly a history of a prior MI, and their baseline EKG and echocardiogram are usually not normal. You can have primary electrical system abnormalities. The other thing to watch out for is the QT interval being belong with LQTS, long QT syndrome. You don't want to miss that. That could cause transient VTach and syncope. And that's something that could occur in a young person. So you have to worry about ventricular arrhythmias also. Okay, and this is probably the most serious cause. So the most important question you're going to ask a patient with syncope: did you feel a prodrome? And the second most important question you want to ask them: do they have any underlying heart disease? Okay. Then there's structural heart disease, aortic stenosis. You could get syncope with aortic stenosis with exertion. If a patient's walking and then they have an episode of syncope, you're going to listen to the chest and aortic stenosis murmur is very difficult to miss. Theoretically, with a hypertrophic cardiomyopathy, you would get syncope post-exertion. These people are going to have abnormal EKGs, tremendous LVH. They're also prone to ventricular tachycardia. The other condition I want to put up here is pulmonary embolism. You can see it with pulmonary embolism. It is clearly not the most common symptom. But if you think of pulmonary embolism, somebody has a large PE, they obstruct the vasculature, you can't get blood from the right side of the heart to the left side of the heart. Nothing goes out into the left side of the heart, nothing goes out. You have syncope, and then you get a little bit of spontaneous reperfusion, and then blood fills. And in certain situations, you at least have to consider this. Next thing, the orthostatic conditions. So if a person says, well, I was lying down and I stood up and I passed out, you need to evaluate them from orthostatic hypotension. Physiologic orthostatic hypotension is related to volume depletion. Patient's very dehydrated, they're over-diuresed, they're bleeding, they're septic. They have a concomitant elevated heart rate. Pathologic orthostasis is due to an abnormality with the autonomic nervous system. It could either be primary, and there are two conditions: pure autonomic failure and multiple system atrophy. Multiple system atrophy could be associated with Parkinson's-like features. And then secondary orthostatic hypotension, long-standing diabetes with a diabetic autonomic neuropathy or amyloidosis could affect the autonomic nervous system. Hypoglycemia in a diabetic, especially on insulin or an oral secretagogue, and they missed a meal, that's something you want to think about. And if it's a diabetic who missed their insulin and you think they were hypoglycemic and they passed out, you don't need a more extensive workup. And psychogenic syncope, that's a diagnosis of exclusion. So these are the causes. So how do you approach this? Number one, a history. Number two, a physical exam. Number three, an electrocardiogram. They do not need a CAT scan of the head. Okay, if somebody falls and they hit their head, you might need a CAT scan of the head. If they have a seizure, they will need a CAT scan of the head. Or if they have a focal neurologic deficit, they will need a CAT scan of the head. Okay, but beyond that, they don't need a CAT scan of the head. The other thing is, They don't need carotid ultrasounds, okay? Carotid disease does not cause syncope. Now, theoretically, posterior circulation disease, vertebral basilar insufficiency, can cause syncope, but there are clearly other neurologic symptoms going along with that. So what tests do they need? It depends. Okay, if you really think this is vasovagal syncope, they might need nothing else. You just need to keep hydrated and avoid the situations that precipitate this. If you're worried about structural heart disease, you're going to get at least an echocardiogram. If you hear an aortic stenosis murmur, you can need to evaluate for aortic stenosis with an echocardiogram and whatever else needs to be done. But you need to let the history guide you. Somebody just blacks out and in the middle of nowhere, no precipitating cause, that's a concern. You're going to admit them. These people need to be admitted. They need to be placed on telemetry, and then you need to attempt to figure out what's going on. And usually they need an echocardiogram. If somebody is orthostatic, then you need to correct the orthostasis and figure out the cause. And there's some medicines like mitadrine or Florinef that are sometimes used. This is not the most common cause, though. The most common thing you see are vasovagal reactions and then probably Stokes-Adams syncope. Okay, there's a kind of mnemonic. I'm not sure how helpful it would be, but let me put it on here. This is called the San Francisco syncope rule, mnemonic's chest. Things to be concerned about: CHF, a low hematocrit, abnormal EKG, shortness of breath, or a low systolic blood pressure. So that's just the mnemonic to have in the back of your mind. And that's it from the trenches. We're going to sign off now.